I'm going to tell you some things that are clinically important. I'm going to let you read your textbook, though. But let's look at the bony structure, what we've got. Now, we've talked about the femur up here. Now we've got to talk about the femur down here. Comes down to condyles, medial and lateral. And then there's a bump on each of the condyles. Epi means upon, so these would be the epicondyles of the femur. We're going to let you palpate these in a moment. If there ought to be a picture in there somewhere that looks something like this, showing you angles. I don't know where, because I didn't even get a copy of the textbook you got. It's the one I got. We talked yesterday, Tuesday. If I say yesterday, I mean Tuesday. I have done nothing since I talked to you. I remember. You have the femur coming down at an angle. Because you've got these wide hips, some of you wider than others. You come down, and the tibia is straight up and down. So where those meet is an angle. Okay? And those angles got names that I can never remember. Fortunately, I don't do children very much. By the time I get them, the knee is worn out, and who gives a hoot anymore? This thing's worn out. I hope the orthopedic surgeon knows about the angle, because he puts it on right. I had one where I swear that orthopedic surgeon missed the angle by 5 degrees, which gave me fits. Because I'm supposed to stretch this knee out, but it's not stretching in the plane I want it to stretch in. I have to keep remembering she's put on wrong. We didn't get a very good outcome on her. That angle is about 170, 175 degrees. Depends a little bit on male or female persuasion. Depends a little bit on the person. Now, the knee structure has to take care of it. And it takes care of it by the menisci in there. Okay? If that angle decreases, you got a problem of wearing on one side. If it increases, you got a problem of wearing on the other side. And it can change over time. I've seen it particularly after fractures. Fractures of the femur or fractures of the tibia where it doesn't heal quite straight. Now, nothing I can do about it except realize I'm going to see you again. I'm going to see you before you have your total knee replacement. I'm going to see you after you have your total knee replacement. Okay. So we've got the angle and the bones. I'm sure somewhere in your book is a nice discussion of it. You can look at it. You either have a increased valgus, increased varus. Holding this structure together are the ligaments. Now, there are several ligaments in here, and you can look at the minor ones that you're not going to hear about. Let's talk about the major ones. Probably the ones you've heard about the most are the cruciate ligaments. The cruciate ligaments are found in the joint structure. If they are going to fix it, they've got to cut a hole in there. They go in arthroscopically now. And in the library someplace should be a wonderful videotape on arthroscopic knee surgery. Okay, I've got a gal who normally wouldn't be treated. She's in her 40s. She's a nurse, but she insists on doing taekwondo. Okay, not all cruciate ligament tears need to be fixed. But if you're going to kick somebody in the jaw or something like that, the one that's on the ground has to be pretty stable. Okay? Now, there's an anterior and posterior. The easiest way for me to remember it is the location on the tibia that names it. So the anterior cruciate ligament would be found more anteriorly, and the posterior cruciate ligament would be posterior on the tibia. Now, visualize for a moment. You get to play with somebody's knee in a little while. If I have something going from the anterior tibia to the posterior femur, what is it going to stop? What movement? Think of tibia. I want something more basic than that. Yes, they both stop hyperextension.
Bending the wrong way?
Huh?
Bending the wrong way?
No.
Anterior translation.
You can't. Okay, you can't say anterior translation. You got to finish your sentence.
Of the tibia.
It prevents the tibia from going forward. But what does it really do? When I'm walking, is my tibia going to go forward? It's in place.
In swing phase.
It's going in swing phase, yeah, but we don't have a lot of stress on our extrinsic fleet. It prevents the tibia from going anteriorly, or it prevents the femur from going posteriorly. Are you with me? Now, what does the posterior cruciate ligament do? The opposite. Anybody here play football? Well, why not? Hey, there's that gal who wants to be the punter on some team. I'm all for her. If she can out-punt the guys, why not let her punt? Heck, if she can out-tackle the guys, why not let her tackle? Be more fun out there. Okay. What's a no-no? You're not really supposed to hit from behind and force the tibia forward, are you? Not supposed to do that because that will tear. Now, these are also involved in rotation. You can also tear it doing taekwondo. Why? Because you're moving and rotating. Okay, sudden movement and rotation and hyperextension or something like that at the same time, yeah. By the way, what is the term for hyperextension of the knee? Give you a new term. That term, people, what's a knee?
Patella.
No, that's not a knee. Looking for the Greek for knee. Genu. Anytime you see genu anything, it's the knee. And hyperextension is recurvatum. So genu recurvatum means hyperextension of the knee. If you want to sound sophisticated in the PTA quiz bowl, you should know that. Okay. So we have the cruciate ligaments. I'm hoping in orthopedics they spend a long time, because I don't have a long time on those. Okay. Any joint that flexes or extends is going to have a pair of ligaments. They're best known in the knee, but they're collateral, together on the side, yeah. And guess what? One of them on this side is called, and one on this side is called lateral. So you have a medial collateral ligament that goes from the femur, epicondyle, to the tibia, and it attaches to the joint capsule. We'll talk just a little more about the joint capsule in a minute. Then you have a lateral collateral ligament that goes from the femur, epicondyle, to the head of the fibula. Now, is the fibula part of the knee joint? Other than it allows attachment for structures, no. By the way, I hope whoever does the ankle mentions this. This The proximal tibiofibular joint is part of the ankle joint. It is part of the ankle joint. And sometimes people will have knee pain after a sprained ankle. Make sure they point exactly to the knee pain. If it's right here, they think it's part of the knee, but it's not. It's a problem here. And you will look very, very smart in clinics if you pick that up. Okay. It's part of the ankle because actually down there, the mortise has to get bigger and smaller. Okay, and that is the fulcrum for it. Okay. Which, don't yell out the answer quickly, think about it. Which of these collateral ligaments is most likely to be injured? Now think about, what do they do? What does the medial collateral ligament do? Prevents the tibia from moving laterally, right? Because when you start moving a tibia laterally, it gets taut. Okay. And what does the lateral collateral ligament do? Okay, now don't yell out an answer. Think. Which of those is more likely to be injured? Don't yell it out. What is the most dangerous creature for older patients? I've argued for a long time that the most dangerous place for older patients is church. Before and after church.
Children.
Huh?
Children.
Children! They come running and they take the old lady out. Okay, now, think about it a moment. Which is more likely to be injured, medial or lateral? Yeah.
Medial.
Why?
Because the danger is going to come laterally.
The danger comes from the outside, hits the knee, and pushes the whole structure in, which is going to stretch the medial collateral ligament. And it